speaker is Dr. Teresa B. Joseph. Her topic is ocular manifestations in patients with psoriasis attending a tertiary healthcare center. Over to you.
Good morning. My paper is on ocular manifestations in patients with psoriasis attending a tertiary healthcare center. Introducing the topic, psoriasis is a systemic condition affecting 1 to 3% of the world's population. It's a chronic inflammatory disease affecting the skin. It's an immunocellular dysfunction and inflammation, and it manifests as erythematous and squamous plaques. Ocular manifestations in psoriasis may be due to direct or indirect mechanisms. Direct mechanisms include eye involvement with psoriatic plaques, and indirect mechanism involves immune-mediated inflammatory response. Aim and objective: early detection of ocular manifestations observed in patients with newly diagnosed psoriasis, and to detect and report any changes in the retina using OCT. Materials and methods. Study design: it was a cross-sectional study. Study setting: in the Department of Ophthalmology and Dermatology in the Tertiary Healthcare Center. Sample size included 50 patients with newly diagnosed psoriasis. Those patients who had signed and informed consent and those obtaining high quality OCT images, that is signal strength more than 6 out of 10, were included in the study. And those patients with history of ocular trauma, ocular surgery, and with Stevens-Johnson syndrome were excluded from the study. Method of data collection: 50 patients with newly diagnosed psoriasis were selected. Detailed history and examination were done, and OCT macula and RNFL were recorded. Coming to results, out of the study sample, 54% were males and 46% were females. Visual impairment was found in 32% of the patients, and the rest retained normal vision. The ocular manifestations found were dry eye, keratoconjunctivitis, blepharitis, uveitis, episcleritis, and cataract. The corresponding percentages of these manifestations were: dry eye was found in 40%, keratoconjunctivitis in 30%, blepharitis in 14%, uveitis in 12%, episcleritis in 8%, and cataract in 20%. The mean IOP among the study sample was 14.26 mm mercury. Mean photostress recovery time was 19.15 seconds. Mean RNFL thickness was 92.54 microns, and mean central macula thickness was 258.90 microns, which were all within normal limits. Coming to discussion. Psoriasis, being an immune-mediated disorder, affects the lacrimal and meibomian glands, and therefore causing dry eye, which is the most common ocular finding. Normal eyelid flora is disrupted in psoriasis, leading to an overgrowth of ocular staphylococcal species, leading to blepharitis. Pro-inflammatory cytokines like TNF-alpha and IL-6 are increased in psoriasis, leading to increased oxidative stress, thus leading to secondary cataract formation. Coming to some previous studies, Carlia et al. In the study Ocular Manifestations in Moderate to Severe Psoriasis in India, a prospective observational study conducted in 2022, concluded that most common ocular pathologies observed in the study were anterior blepharitis and moderate dry eye. Cosby et al. In the study Psoriasis and Uveitis, conducted in 2022, concluded that relation between non-arthritic psoriasis and uveitis have not yet been fully elucidated, and that physicians who treat this disease must be cautious and refer their patients to an ophthalmologist even if they do not have any ocular symptoms. Concluding, psoriasis have several ocular manifestations even at the start of the disease, many of which leads to visual impairment as well, such as uveitis, keratitis, and cataract. Most of these are curable, and further complications like corneal ulceration due to severe dry eye can be prevented by timely detection and treatment. Hence, patients with psoriasis should undergo regular eye examination regardless of risk factor to monitor for progression of ocular manifestations. These are the references. Thank you.
So you have shown the pictures, because iritis or something. Is it Indian picture or something different, feminist?
Sir, iritis was not there, blepharitis was there.
Blepharitis was,
Yes, sir.
but you have shown some iris picture, that is something appears to be a, not
No,
belong to
sir,
the
it's
Indian.
an Indian picture.
Indian picture. Your
sir.
patient's picture.
Yes, sir.
Sure.
Yes, sir. Yes, sir.
Okay. Because when you present, no, you must have all our own pictures only. Have you done any HLA relations? No.
Excuse me, sir?
HLA association with HLA.
No, sir.
You have not done. Okay, thank you.
Thank you.
Next speaker is Dr. Jilisa OP, presenting on pattern of dry eye associated with face mask use during COVID-19 by OSDI score. Over to you.
Good morning. My paper is on pattern of dry eye associated with face mask use during COVID-19 by OSDA score. Introduction. Dry eye is a multifactorial disorder of ocular surface characterized by symptoms of discomfort, visual disturbances, tear film instability with a potential damage to ocular surface. Emergence of COVID-19 pandemic resulted in widespread use of face mask, and there is marked increase in dry eye symptoms among regular mask users, that is known as mask-associated dry eye disease or MAID. Face mask can cause dry eye due to many mechanisms like the increased airflow probably hastening the evaporation of tear film, causing ocular surface irritation and inflammation, and increasing carbon dioxide inside a face mask could result in changes of the corneal nerve sensation and induce inflammation. Objective: to study the pattern of dry eye associated with face mask in patients presenting with the symptoms of ocular irritation. Materials and methods. Study design is a cross-sectional descriptive study, period over 12 months, and study population, patients attending OPD wearing mask and having symptoms of dry eye. Study tool is a structured proforma, including ocular surface disease index questionnaire. Sample size is calculated as 285. Inclusion criteria: 18 to 65 years of age, wearing mask and having symptoms of dry eye. Exclusion criteria: other causes of dry eye and patients with symptoms of dry eye for more than 1 year, and patients who are unable to comprehend the OSD questionnaire. Study procedure: patients are selected by random sampling, informed consent taken, and OSD questionnaire is used to classify the patients into normal, mild dry eye, moderate dry eye, and severe dry eye based on the OSD scores. It is a validated questionnaire having 12 questions under 3 subscales. And this equation used to calculate the score, and the subjects are classified into various groups for analysis. Results: distribution of population based on severity of dry eye as per mean OSD score. 52% had dry eye and 48% were normal. Among all these, 15.1% were mild, 33.7% was moderate, and 3.5% was severe dry eye. And based on type of face mask used, 74% used N95 mask, 23% used triple layer mask, and 3% used cloth mask. Based on type of face mask used and dry eye status, none of the cloth masks had dry eye. 50.2% of the N95 mask users and 67.2% of the surgical face mask users had dry eye. Based on hours of face mask usage, 56% used it more than 8 hours and 44% used it less than 8 hours. And based on dry eye based on the hours of face mask usage, it was more among those who used it more than 8 hours, that is 75.6% in 8 to 12 hours and 71.6% in more than 12 hours. Based on age groups and dry eye status, it was highest among 31 to 45 years, that is 73.5%, and none above more than 60 years had dry eye. Based on gender and dry eye status, male to female ratio of the population was 56.1 to 43.9, and 50.4% of the males and 53.8% of the females had dry eye. Discussion: by comparing with some previous studies based on prevalence, a study of Laura Bagoda in 2020 showed that 18.3% had mask-associated dry eye. The higher prevalence of dry eye in our study, that is 52%, may be because it was conducted a bit later period of COVID pandemic, when the use of face mask might have considerably increased. And based on the type of mask, by a study of H.S. Shalaby et al., He compared surgical face mask and N95 mask, and surgical mask had a greater drying effect compared to N95, and this was consistent with our study. And based on duration of face mask wear, by study of Zakaria et al. On 67 subjects, he found that those who wear face masks for at least 6 hours per day, 5 days per week, showed a higher incidence of their OSD score as compared to standard users. And by study of AIMS Hyderabad in 2023, among 114 healthcare workers, using OSDA questionnaire, wearing mask more than 3 to 6 hours per day contribute or worsen symptoms of dry eye disease. This was consistent with our study. And conclusion, significant increase in prevalence of dry eye in subjects using face masks. The type of face mask used and chosen to wear also play a role. Severity of dry eye disease increased with the increase in hours of face mask usage. Using a better type of mask that is tighter at the nostril, decrease the frequency of mask use may prevent development of may increase complaint to the use of face mask also. The limitation of the study, the diagnosis of dry eye disease and information about duration of face mask was purely subjective, and lack of objective monitoring of the study subjects regarding method of mask use and proper sealing. And dry eye caused by use of digital screen which had equal relevance was not explored in this study, and other factors influencing dry eye like environmental information were not taken into consideration. My references. Thank you.
What's the reason for this onset of dry eye in these patients?
Because the airflow into the eyes, and the warm air, exhaled air into the eyes can cause dry eye due to evaporation of tear.
Did you find out the Meibomian gland functions and all in these cases? Any reason could be associated with the Meibomian gland dysfunctions?
No, sir.
That means all surgeons will have, no? Suppose we are doing cataract surgery and all, we have been washing face masks, all of us will be having dry eye then. Then for us, what face masks do you advise? Surgical face mask or N95?
I'll be advising N95 mask as it has more approximation and less airflow towards the eye.
Because you are using daily, no? Face masks and all.
Yes.
Okay, thank you.
Thanks.
Your research, your other studies also showed that N95 is having less effect, no? Why that N95 is having less dryness compared to the surgical mask?
N95 have more sealing than surgical face mask.
Yeah.
So the airflow into the eyes will be lesser compared to the surgical mask.
So this study, you have asked a questionnaire, no, about how many hours they uses. Did you ask the question whether you are using over the nose or over the mouth? So the duration can totally will vary. And another this thing, because when I used to use this one, I used to tape it here. So that means there won't be any dryness, no?
And
if I drape it here with a plaster, this dryness will disappear, no? Are you correct?
the sticking
Airflow won't come, no?
Sticking of the paper on the lower eyelid will change the position of lower lid also, and mechanical agrothermal.
That is the reason you explain that N95 is having less dryness because it is sealing better. Okay, if you seal it totally, like sir asked, when you are going into the theater, most of the surgeons will be sticking, no, so that to avoid that fogging. So maybe that helps. Thank you.
Thanks.
Now we have Dr. Grishma Marin Sebastian to speak on to evaluate the risk factors of retinal vein occlusion, a retrospective study.
Good morning. My topic is evaluation of the risk factors of retinal vein occlusion in South Indian population. Introduction. Among the retinal vascular diseases, the most common is diabetic retinopathy and the second most common is retinal vein occlusion. The most common associations of retinal vein occlusions are hypertension, diabetes and atherosclerosis. Other associations are inflammatory, infectious and hematologic disorders. And it provides a unique opportunity for ophthalmologists to contribute to the patient's medical care. Most of the reported literature are from Western countries. Our Indian subcontinent has limited number of literature. Aim of the study to evaluate risk factors of patients who presented with retinal vein occlusions in a tertiary eye hospital in Kerala, South India. The study design is hospital-based chart review, and the study population is all patients who were diagnosed with retinal vein occlusion, and the study duration is from January 2021 to December 2023 at a tertiary care center, South India. So, out of all the retinal vein occlusion patients has been divided into two groups, that is group A who constitutes more than 50 years of age, and group B who are having less than or equal to 50 years of age, and each of these groups were divided, again subdivided into central retinal vein occlusion, branch retinal vein occlusion and tributary vein occlusion. Known risk factors at presentation were recorded and others were investigated for risk factors and noted. Inclusion criteria: all patients diagnosed with retinal vein occlusion with at least one follow-up visit. Exclusion criteria are the patients diagnosed with retinal vein occlusion without any follow-up visit. So the risk factors includes both systemic and ocular. Systemic risk factors are systemic hypertension, diabetes mellitus, hypercholesterolemia and homocystinemia. Ocular risk factors includes glaucoma and hypermetropia. Coming to results, total number of eyes taken were 615, and it was noted that 90% of the retinal vein occlusion occurred in group A, that is more than 50 years of age group, and 10% occurred in group B, that is younger patients. Coming to distribution of retinal vein occlusion, in group A, that is more than 50 years of age patients, 35% had CRVO, 61% had BRVO and 4% had TVO. In group B, that is in younger patients, 42% had CRVO, 58% had BRVO and none of them presented with tributary vein occlusion. So in risk factors in central retinal vein occlusion, in both groups A and B, the most common were hypertension, diabetes and glaucoma, followed by dyslipidemia, then hypermetropia and homocystinemia, and in group B, that is younger population, hypermetropia was not found as a risk factor. In coming to BRVO, the most common risk factors were hypertension, diabetes, dyslipidemia, then glaucoma and hypermetropia. Homocystinemia was not found as a risk factor in both the groups in BRVO. Coming to tributary vein occlusion, only group A presented with tributary vein occlusion to us, and here the most common risk factors were hypertension, diabetes, dyslipidemia and glaucoma. None of them had homocystinemia and hypermetropia as risk factor. And coming to the multiple risk factors, 84% of the group A and 61% of the group B had multiple risk factors, 16% of group A and 39% of group B had isolated risk factors. So this study was conducted to find out the common risk factors and systemic and ocular associations of retinal vein occlusion in a tertiary care center in South India. In this study, majority of the study population belonged to the age group of more than 50 years, which accounted for around 90%, which indicated that the prevalence of retinal vein occlusion increases with age. Coming to literature, Beaver Dam eye study by Klein et al. And the study population taken were CRVO and BRVO. They concluded that the common risk factors were hypertension, pulse pressure and diabetes mellitus. And another study in Italian population by Edoardo et al. Concluded that age, smoking and diabetes mellitus are the common risk factors in a group of CRVO. Meta-analysis done by Peter Kohler in a population of CRVO and BRVO concluded advanced age, hypertension and diabetes mellitus as the common risk factors. And another study from India, that is from Surat, Gujarat, India by Kushnuth et al. Concluded that hypertension, dyslipidemia and homocystinemia are the most common risk factors, and the type of RVO taken was BRVO. Our study, which was done at a tertiary care center, South India, and we had the subpopulation of CRVO, BRVO and tributary vein occlusion, concluded that the common risk factors were age, hypertension, diabetes mellitus and dyslipidemia. The group B with young patients also had similar risk factors as of group A. Risk factors suggestive of hypercoagulable states on investigation were not found in group B. In age group of less than 50 years, no patients of tributary vein occlusion presented to us. Isolated risk factors accounted to few. Majority had multiple risk factors. The number of patients having isolated hypertension and diabetes mellitus as risk factors accounted to 6.9%. And additionally, hypermetropia as a risk factor was seen, and it accounted as a risk factor in 4.3% of the patients, and that too mostly it was seen in younger population, that is group B. So strength of the study was other South Indian studies are limited, and limitations are it is a retrospective chart review, so possibility of incomplete data, and couldn't identify patients with systemic risk factors presented to ophthalmologists for the first time. Coming to conclusion, in our study also advanced age was an important risk factor. Other than age, the most common risk factors were hypertension and diabetes in both the age groups. Homocystinemia was not found to be a major risk factor. Hypermetropia as a risk factor was present in a few patients, mostly in group B. So I extend my sincere gratitude to all my consultants and the institution and all the people who helped in their collection of data. Thank you.
You already told that glaucoma also one of the reasons, but in the
That was
conclusion you have not shown.
that was only in one group,
But
CRVO
glaucoma,
group.
usually whenever see CRV occlusion, you are supposed to rule out glaucoma, open angle glaucoma particularly. You told now tributary vein occlusion. Which tributary was affected more in your study? Which is draining macula, something like that?
Draining macula, draining the macular area.
You have not taken photographs or no?
No, sir.
Okay. You told now atherosclerosis. Atherosclerosis, which part of the retina is affected? You know that? So for fun, this is only, don't take it seriously. You know one thing, atherosclerosis will never be seen in retina. Please remember this.
Next, thank you, Dr. Grishma. Next, we have Dr. Litty KS talking on patterns of orbital wall fractures in patients presenting with road traffic accidents.
Good morning. My paper is Pattern of Orbital Wall Fractures in Patients Presenting with Road Traffic Accidents in a Tertiary Care Center. Orbital trauma is one of the most common emergency department consultations and is often accompanied by trauma of the facial bones and soft tissues. The incidence of orbital fractures is increasing due to the rising number of road traffic accidents, sports-related injuries, and physical assaults. Mostly young adults are involved in these accidents, and it leads to both functional and cosmetic deformities for the patient. Though the orbital fractures are very frequent, they are rarely addressed in ophthalmic literature. Hence, a study is done to describe the pattern of orbital wall fractures in a tertiary care center where polytrauma is dealt with routinely. The study aims at evaluating the patterns of orbital fractures in patients presenting with road traffic accidents. Methodology: this descriptive cross-sectional study is done in 62 patients who presented to the emergency care department who were diagnosed to have orbital fractures by CT scans. Demographic details and details of orbital wall fractures were recorded, and patterns of orbital wall fractures were noted as isolated, medial, lateral, roof and floor fractures or involvement of multiple walls. Details of involvement of midfacial region, zygomatic bone and optic canal was also noted separately. Each wall fracture was then classified into displaced or undisplaced. The collected data was analyzed using SPSS version 20. The qualitative variables were expressed in percentages. Results: out of the 62 patients, males predominated the study compared to females. Majority belonged to the age group of 40 to 60 years, which was followed by 19 to 39 years and then more than 60 years. So combined fractures were more compared to the isolated bone fractures. Among the isolated orbital wall fractures, the most common was the orbital floor fracture, followed by the lateral wall, then comes the medial wall, and the least commonly fractured was the roof. So in males and females, the most common orbital wall to be fractured in males was floor, and in females it was the lateral wall. In both males and females, it was the least commonly fractured was the roof. So unilateral fractures were more compared to bilateral fractures. 17.8% had involvement of zygomatic bone and only one patient involved the midfacial region. Among the total orbital wall fractures, majority had no displacement of the fracture segments compared to the one with displaced fragments. Only one patient had optic canal injury. So this study is comparable with the study by Bethany et al., where there was a male predominance in the study population. This could be due to the increased motor vehicle usage by males compared to females. The study by Formet et al. Revealed involvement of age group between 21 to 40 years, whereas most vulnerable population belonged to 16 to 25 years in the study conducted by Kashinada et al. This means that the young adults are more commonly involved. The commonest combined wall fracture involved lateral and floor fracture. And the total orbital fractures, the most common was of the floor, followed by lateral and medial wall in the study. So in the study conducted by Bethany et al., single wall fractures were more than the combined orbital wall fractures, and the most affected site was floor, which was similar to our study. The study by Cornelis et al. Showed that most common was orbital floor fracture and least was the medial wall fracture. The most common isolated bone fracture site was orbital floor in the study conducted by Joanna Moffett et al., which is consistent with our study results. Majority of the fractures were non-displaced. 11 patients had involvement of the zygomatic bone. In the study conducted by Karing et al., zygomatic bone fracture was the most common fracture, followed by the orbital floor fracture. Orbital wall fractures sustained following road traffic accidents predominantly affected males, and the most common orbital wall to be fractured was the floor. Most fractures were combined with no displacement of the fracture fragments. Among the combined bone fractures, mostly commonly involved were lateral wall and floor fractures. Reference. Thank you. Thank you.
Very nice presentation.
Why you think the floor is the most common area affected? What is the reason for that thing?
Probably because the floor, we have the maxillary sinus, so it might be the thinnest because
Thinnest
of the
part of it. Okay. Thank you.
Yeah, thank you, Dr. Litti. Next, we have Dr. Izadem Fahida Rafi. She'll be talking on visual outcome in patients at first 1 year post blunt trauma treated at a tertiary care center.
Good morning, everyone. My topic for paper presentation is visual outcome in patients at 1 year post-ocular blunt trauma treated at a tertiary care center. Aim of study is to determine the visual outcomes in patients who sustain blunt trauma and to compare visual outcome with predicted visual outcome according to the ocular trauma score study. Materials and methods: study design, prospective cohort study. Study duration is of 1 year. Sample size 32. Study population: all male and female patients coming to Department of Ophthalmology having sustained ocular blunt trauma treated and followed up here itself. Inclusion criteria: patients of all ages, both males and females. Exclusion criteria: those with previous ocular disease, those with head injury, severe chest and abdominal trauma, those not able to come for follow-up, and unconscious patients. Study variables: demographic characteristics, place of injury, and OTS score, that is score of 1 for 0 to 44, 2 is for 45 to 65, OTS score 3 is for 66 to 80, and 4 81 to 91, and OTS score 5, that is 92 to 100. Results: this prospective cohort study was done in a tertiary care center. 32 patients fulfilling the inclusion criteria were included in our study. There were total of 32 patients. Among that, 20 were males and 12 were females. The age of presentation was less than 10 in 5, 11 to 20 in 8, 21 to 30 in 5, 31 to 40 in 4, 41 to 50 in 6 patients, and more than 50 in 4 patients. Regarding the occupation, 12 were students, 7 were professionals, 2 were skilled worker, 1 unskilled worker, 2 manual laborers, and 8 household workers. Place of injury: out of 32 patients, 3 sustained injury from workplace, 13 from home, 4 from school, 1 from road, and 11 patients sustained injury from other areas. Zone of injury: about 17 patients had injury to cornea and limbus, 14 patients to cornea, limbus, anterior segment and posterior segment, and only one of the patient had injury only to the posterior segment. Initial best corrected visual acuity, that is at the time of presentation, about 15 patients had initial BCV of 6 by 6 to 6 by 12, 13 patients 6 by 18 to 6 by 36, 3 patients had 6 by 62, counting fingers close to face, and one of the patient had BCV of range, hand movements to perception of light. Then ocular trauma score. Ocular trauma score, about 17 patients had trauma score of 5, that is 92 to 100. 14 patients had ocular trauma score of 4, that is 81 to 91. And one of the patient of my study only had 45 to 65, that is OTS score of 2. BCVA at 6 months for OTS. As the OTS score is high, the probability of having better BCVA at 6 months follow-up is higher. And from my study, I could found that 28 of the patients had 6 by 6 to 6 by 12 at 6 months, and 4 of the patients had 6 by 18 to 6 by 36 at 6 months. And 78% had edema, ecchymosis of lids and adnexa. 25% had chemosis and congestion, 65.5% had Descemet's membrane folds, 18.8% had sphincter tear, 25 patients had AC hyphema, 1 patient had subluxated or dislocated lens and phacodonosis, vitreous hemorrhage in 10 patients, and IOP was more than 21 in 14 patients, commercial retinal seen in 13 patients, retinal hole and hemorrhage in 2 patients, no retinal detachment noted in my study. Treatment: 28 received topical drugs like antibiotics, anti-glaucoma medication, cycloplegics, and steroids. Two of each received medical surgical treatment like AC paracentesis, usage of bandage, contact lens, and others. And two also received medical BCL and barrage laser. BCVA at 1 year of trauma. About 30 patients had BCVA at 1 year of 6/6 to 6/12, and 2 patients had 6/18 to 6/36. Discussion: higher incidence of ocular trauma was noticed in male workers in this study, which was similar to study by Nirmala P. et al. Patel et al. Also found ocular injuries were more common in males. The majority of patients, that is about 25%, were between the ages of 11 and 20 years, which was similar to my finding. From our study, it was also found that if the OTS score is high, the probability of having better visual acuity at final follow-up is higher. Similarly, as the OTS score is high, the probability of having better BCV at 6 months follow-up is also higher. And Ray et al. Also found that high OTS score is associated with good visual prognosis, which was similar to our findings. Conclusions: as already said, BCVA at presentation was about 6/6 to 6/12, which was seen in 15 patients, and 6/18 to 6/36 in 13 patients, and 6/62, counting fingers close to face, only seen in 3 of the patients, and hand movements to perception of light seen in only 1 patient. And when we followed up, we got the BCVA at 1 year as 6/6 to 6/12 in 30 patients, 6/18 to 6/36 in 2 patients. And OTS score was also 17 patients had OTS score of 5, 14 patients had OTS score of 4, and only 1 patient had OTS score of 2. So overall, this study reinforces the value of the OTS in predicting visual prognosis and improving the management of blunt ocular trauma, ultimately contributing to better patient outcomes and more effective use of healthcare resources. Thank you.
How did you calculate this OTS score?
Sir, actually this OTS score has got certain variables like initial visual acuity, globe rupture, perforating injury, retinal detachment, and RAPD. And my patients were only confined to blunt ocular trauma patients. So my main study variable was visual acuity, initial visual acuity.
This score was given during injury or after 6 months?
No, at the time of injury.
At the time of injury.
Yeah, and this score helps us to know the visual prognosis, and if higher the OTS score, then the prognosis will be good, and we can get it on BCV at 6 months.
DM fold, decimal membrane folds.
Yeah.
What was the IOP in those patients?
Sorry?
What was the IOP, intraocular pressure, in those patients?
Actually, IOP was found to be more than 21 in 4 of my patients.
You told DM folds.
Yes.
About some patients, 11 patients or something you told. In them, what was IOP?
Not everyone had more than 21.
See, decimal folds can occur only when there is a low IOP. Please remember.
Only 4 patients had IOP more than 21 in my study, out of 32 patients.
And we expect decimal tear to occur in a case of raised intraocular pressure. That's normally.
So you had household injuries more, no?
Yes, sir.
What was the type of injuries?
Household injury mainly seen in female patients from trauma by hitting by the child, like that.
Okay. Thank you.
Next, we have Dr. Aishwarya S. presenting on role of hematological and clinical biomarkers in diabetic retinopathy in type 2 diabetic patients.
Good morning all. My study is on role of hematological and clinical biomarkers in diabetic retinopathy in type 2 diabetic patients. The incidence of proliferative diabetic retinopathy is increasing even in youngsters in our population, and this study aims at reassessing any changes in the metabolic profile of the diabetic retinopathy patients. Aim of the study is to determine the associated hematological and clinical risk factors of diabetic retinopathy among type 2 diabetic patients and to determine the association of these risk factors with the severity of diabetic retinopathy. It is a cross-sectional, observational and descriptive study involving 100 patients. All patients of type 2 diabetes mellitus with diabetic retinopathy who presented in the ophthalmology outpatient department in a tertiary care center for a period of 1 year were included in the study. And type 1 diabetes mellitus, gestational diabetes mellitus, pre-existing renal disease, and those patients with history of any intraocular surgery in the past 3 months, retinal laser photocoagulation and intraocular injections were excluded from the study. Complete ophthalmological examination was done by assessing visual acuity with Snellen chart and with the help of slit lamp and fundus examination. Lab investigations were sent including fasting blood sugar, lipid profile, HbA1c, hemoglobin, and nephropathy screening was done with the help of albuminuria, blood urea and serum creatinine. Systolic and diastolic BP was measured and BMI was calculated. Data collected from each individual was entered in MS Excel after coding of variables, and Fisher exact test was done with the help of SPSS software. Ethical clearance was attained from IRC and IEC. Going on to results, 200 eyes of the 100 patients were studied and the mean age of the study population was 58.37 years. Most of the patients belonged to the moderate NPDR group, accounting for 36.5%, and 9% of the patients had PDR, 22% of the patients had maculopathy. As the severity of diabetic retinopathy increases, the incidence of hypertension also increases, but it was not found to be statistically significant, with 44.4% of the PDR patients having hypertension. 61.1% of the patients with PDR were overweight and it was found statistically significant. However, a significant association could not be found between BMI and maculopathy. As documented in literature, in our study as well, both PDR and maculopathy had a significant association with poor glycemic control, with 82.9% of the PDR patients and 84.1% of the maculopathy patients having poor glycemic control. Even though the incidence of anemia was more among PDR patients and maculopathy patients, it was not found to be statistically significant. PDR and maculopathy had a significant association with high cholesterol levels, with 77.8% of the PDR patients and above 80% of the maculopathy patients having high cholesterol levels. High LDL also had a significant association with diabetic retinopathy severity and maculopathy, with 66.7% of the PDR patients and 81.8% of the maculopathy patients having high LDL. However, HDL and triglycerides were not found to have a significant association with diabetic retinopathy severity and maculopathy. Both PDR and maculopathy had a significant association with albuminuria, with 88.9% of the PDR patients and 52.3% of the maculopathy patients having albuminuria. A significant association was also found between PDR and maculopathy with deranged RFT, with 50% of the PDR patients and 29.5% of the maculopathy patients having elevated urea levels, and 72.7% of the PDR patients and 34.1% of the maculopathy patients having elevated creatinine levels. Now going on to discussion, a study done by Deepsi Saini et al. Documented that there was a significant association with nephropathy and diabetic retinopathy, and in our study as well, we got a significant association between the severity of diabetic retinopathy and nephropathy. According to Sack-Nixon et al., high systolic BP had a significant association with diabetic retinopathy severity, but in our study, we did not find such a significant association. According to Shankara Netralaya Dreams Report 33, high BP, poor glycemic control, anemia, high LDL and microalbuminuria had a significant association with diabetic retinopathy severity. However, in our study, poor glycemic control, high LDL and albuminuria were found to have a significant association. And going on to conclusions, the severity of diabetic retinopathy and maculopathy had a significant association with poor glycemic control, albuminuria, deranged RFT, high LDL and hypercholesterolemia. Being overweight had a significant association with PDR but not with maculopathy. Hypertension, anemia and triglycerides had no statistically significant association with diabetic retinopathy severity and maculopathy, but they were clinically significant. HDL had no clinical and statistically significant association with the severity. And these are my references. Thank you.
In one studies slide I have seen, hypertension in PDR is about nearly 44%. And the last slide was shown now that hypertension is not so significant. That's why you told hypertension was significant in PDR. 45%.
So hypertension was more among PDR patients. It was clinically significant, but on statistical analysis, the p-value was more than 0.05. Sir. So there was no statistical significance. However, hypertension among the PDR patients, hypertensives were more as compared to other mild, moderate and PDR groups.
Statistics and all you have done, or somebody helps you?
I have done so.
You know
With
statistics?
SPSS software, with the help of community medicine department.
Oh, that's one. Okay, thank you.
Thank you, sir.
So the cholesterol also is related, no?
So high cholesterol levels have got a significant association,
But not with the triglycerides.
but not in my study there was
But
no.
other studies they have shown relationship.
Yes, sir. In other studies it have shown relationship.
Because usually we expect if it is a low density lipid, then there will be an association with the triglycerides
as well.
Because your study is shown in the other way compared to the other studies. Do you recommend cholesterol control in diabetic retinopathy?
Yes, sir. Cholesterol control could decrease the progression of diabetic retinopathy. There were studies suggesting decreasing the cholesterol levels. Thank you, sir.
Next presenter is Dr. Anaga Murali. She is presenting a paper on association between primary glaucomas and retinal vein occlusions.
Good morning. My topic is association between primary glaucomas and retinal vein occlusions. So retinal vein occlusion is the second most commonest retinal vascular disease after diabetic retinopathy, which is divided into CRVO, BRVO and HRVO. And there are several risk factors which includes ocular as well as a systemic. The major ocular risk factor is glaucoma, external retrobulbar compression with neoplasm and retinal arteriolar narrowing, which can be secondary to systemic risk factors like hypertension, age, dyslipidemia, diabetes, etc. And the overall frequency of primary angle closure glaucoma was found much higher in patients with retinal vein occlusions higher than in the general population. It was postulated that eyes with primary angle closure glaucoma may undergo mechanical changes in the lamina cribrosa, resulting in retinal vein occlusions, and the raised IOP can compromise retinal vein outflow and produce stasis. And several population-based studies have shown that changes in retinal vasculature are associated with optic nerve damage and glaucoma. And in this study, the patients who are presenting with painless defective vision, who had with or without RAPD and all the fundus examination corresponding to the retinal vein occlusions, they were diagnosed as retinal vein occlusions. And the objective of my study was to determine the proportion of primary glaucomas, that is a primary open angle and primary angle closure disease in patients with retinal vein occlusions. It was a descriptive cross-sectional study conducted over 1 year, and all the patients who are diagnosed with retinal vein occlusions at our institution during the study period was taken. And the sample size was calculated using a similar study done at Nepal, and the sample size was calculated as 334 and loss to attrition was 12, hence the total sample size reduced to 322. And all the cases of CRVO, BRVO, HRVO presenting within 1 year of onset was included, and all those who were diagnosed more than 1 year and all other causes of secondary glaucoma were excluded. And consecutive sampling was done. After getting approval from the IRB, the informed consent was taken from all the patients, and detailed ophthalmological examination was done, slit lamp examination, applanation tonometry, gonioscopy, fundus examination, and they were classified as primary open angle or primary angle closure disease. HFA was used for perimetry, OCT was taken for RNFL thickness and macular edema quantification, and the data was analyzed using SPSS version 23. And the results was, the first result is among the 322 cases studied, 196 were BRVO, 108 were CRVO and 18 were HRVO. And sex-wise distribution, we could see that the males were more commonly affected compared with the females, accounting for 64.29%. And age-wise distribution, here we can see more than 40 years, majority of the patients were in the category more than 40 years. That is, more than half of the patients came in the category of more than 60 years. Between 40 to 60 years, 131 cases were recorded. And the association between primary glaucomas and retinal vein occlusions, that is a total of 190 patients out of the 322 had primary glaucomas, that is 59.07%, out of which 98 patients, that is a 30.43%, had primary angle closure disease, 92 patients had primary open angle glaucoma, 28.57%. This is a CRVO. In 33.3% had primary angle closure disease and 31.48% had primary open angle glaucoma. In BRVO, 28.57% had the primary angle closure disease and 27.04% had primary open angle glaucoma. In HRVO, 33.3% had primary angle closure disease and 27.7% had primary open angle glaucoma. And among the 322 samples, the 64.29% were males, and the results were similar to our parent study conducted by D. Sherpa et al. And in our study, majority of the patients were above 60 years, and it was also similar to that of the study conducted by D. Sherpa et al. And from our study, we could conclude that retinal vein occlusions were predominantly a disease of the elderly. And also, in our study, 28.57% patients had POAG and 30.43% had PACD. PACD is more prevalent in retinal vein occlusions than POAG. The proportion of retinal vein occlusion obtained in our study was higher than the similar study conducted by D. Sherpa et al., which was 24%. And so the conclusions from my study is retinal vein occlusions are more common in elderly individuals, especially above 60 years with male sex predilection. And the proportion of primary glaucomas in my study population with retinal vein occlusion was found to be 59.07%, which is quite alarming. 30.43% of the study population had primary angle closure disease, which includes 5 cases of primary angle closure glaucoma and 14 cases of primary angle closure suspect. 28.57% of the study population had primary open angle glaucoma. So while dealing with all these cases, we have to evaluate both the cases, that is retinal vein occlusion. Glaucoma also needs to be evaluated because both of these diseases are potentially blinding diseases, and early presentation to ophthalmologists as well as early diagnosis, treatment and prevention of the complications of the disease is required. And these are my references. Thank you.
The fact that glaucoma is commonly associated with vein occlusions, everyone knows that. You know that glaucoma can affect the vein at which position of, can you tell me, which area of the part of the vein is getting occluded?
At the lamina cribrosa.
That is actually at the edge of the cup. That's called hemispherical occlusions. Understand now? And you are told PSCD. Which stage of PSCD? The glaucoma stage or a suspect stage or a primary angle closure stage? Which stage is more notorious for getting occlusions? You have, in your study, have you ever seen? You told it's a glaucoma case or they have already having cupping and all everything in primary angle closure these glaucoma cases? Primary angle closure glaucoma, you know the stage is difference. Suspect, then glaucoma, and you know the last stage is glaucoma. Glaucoma means they will have field changes and all, cup changes and all, the disc changes will be there. So you have shown that PSCD is more as commonly associated with
vein occlusion.
Vein occlusions.
Primary angle closure patients were more commonly.
How? Because angle closure glaucoma patients will have permanent increase of intraocular pressure. Open angle glaucoma also will have a permanent increase in intraocular pressure. They can produce vein occlusions. How can I say angle closure is more? Or in your study it is more like that?
Yes, in my study it was more, because there will be more angle closure glaucoma patients will present to us with symptoms.
Primary angle closure, only early stages they will come with, they will have some halos and all. Once they develop the glaucoma stage, I don't think they will have similar to open angle glaucoma only they will appear. Primary angle closure, acute stage, only when they develop acute stage of pain or everything they will come to you. Otherwise they will come only with a history of halos and a transient loss of vision. That they can come to you. But I don't know why you have told PSCD has got more, incidence is more for glaucoma. That's the reason I want to know.
The chances of vessel occlusion, the posterior pressure was.
Okay. So usually the glaucoma produces the vein occlusion, no? or in the other way around?
Because it can be
Yeah, that is a pathology you explain, no?
it
But
can,
this study is based on the reverse side, no?
because
You studied on the vein
those-
occlusion, how many are having? But
uh,
this is alarming rate of glaucoma seen in this thing.
because it can be unnoticed and
Yeah.
undiagnosed
And,
set of population.
Yeah, many are angle closure suspects in your study. So whether that added to this high number, because sometimes the angle closure suspects are to some extent could be subjective also.
Subjective.
So that is one thing I was thinking. Okay, thank you.
Thank you.
Next, we have Dr. Sachin V. Suresh. His topic is on clinical applications of ultra-wide field angiography, a retrospective study.
Good morning, all. Our study was on the clinical applications of the ultraviolet angiography. Ultraviolet angiography is a cutting-edge imaging techniques which captures the detailed images of the retina, particularly the peripheral regions, which are often missed by the conventional imaging methods. The ultraviolet consists of an ellipsoidal or parabolic mirror, which gives a wide scanning angle even without the pupillary dilatation. Unlike the traditional angiography method, which covers only 45 degree to 100 degrees of field of view, ultraviolet field gives an field of view up to 200 degrees, which covers up approximately 875 millimeter square of the retinal area. This is an ETDR standard 7 field. ETDR standard 7 field, which consists of a 30 degree circle which extends horizontally 70 degree and 75 degree vertically. And this is an ultraviolet field image showing the different parts of the retina, posterior and mid periphery and far periphery in a single shot. Our aim was to evaluate the clinical applications of the ultraviolet field and in the detection and management of various retinal pathologies, and to compare the ultraviolet field with a conventional angiography. It was a retrospective analysis of 69 IC35 patients and compare with the ultraviolet field and conventional angiography. The study period was of 11-month study period. The pathologies studied were retinal vascular pathologies. The common parameters we have included is the ischemic changes in the central mid-periphery and neovascularization in the posterior pole and mid-periphery, and peripheral vascular leakage and disc leak and vascular stasis. Coming to the result, the detection of the retinal ischemia, the ultraviolet field had a higher hand in both the mid-peripheral and peripheral region, and the sensitivity and negative predictive value was 100% for the ultraviolet field, and the specificity and positive predictive value varied differently in the mid-peripherally. Ultraviolet field can also calculate the ischemic index. It is the percentage of the ischemia of the total retinal area. The pixels contained in the non-perfused area are calculated and divided by the number of the pixels on the whole retinal surface area. It is important because it can differentiate between ischemic versus non-ischemic CRVO, and in recalcitrant diabetic macular edema, ISA will be high. Coming to the detection of neovascularization in the periphery is easily missed by the conventional angiography methods, which is easily picked up by the ultraviolet field. The detection rate was for ultraviolet field was about 5 times higher than the conventional angiography. The sensitivity and negative predictive value was 100% for the detection for ultraviolet field for the detection of the neovascularization. The specificity was also high, and the positive predictive value slightly differed in the mid-peripheral region. And coming to the peripheral vascular leakage, it was a leakage from the retinal vessels seen as hyperfluorescence extending beyond the vessel wall, occurring in the setting of active retinopathy. PVL has been linked to peripheral non-perfusion and neovascularization. Coming to the detection of PVL, the ultraviolet field had excellent ability to detect the PVL, whereas the conventional angiography failed to detect any of them. The disc leak was detected by both the conventional and ultraviolet field in a similar manner, and the negative predictive value for all the three clinical conditions were high for the ultraviolet field. Summary of our result: ultraviolet field had a higher hand for detection of ischemia neovascularization, PVL, and vascular stasis, especially in the peripheral regions. And sensitivity and negative predictive value was 100% for all the conditions, suggesting its excellent ability to rule out negative results. PPV positive predictive value was varied for all the conditions except the disc-click, which suggests some false positive result may present in lesser extent. The accuracy and positive likelihood ratio was also suggestive of ultrawide field's excellent ability to detect pathologies, especially in the peripheral regions. The similar studies by the Bessel et al., Patel et al., and Silver et al., and Tox et al. Extensively corroborated with our study, suggesting the ultrawide field capability to detect retinal no perfusion, vascular leakage, and neovascularization in the peripheral retina, and ultrawide field's ability to detect peripheral vascular pathology in various retinal diseases, and it's higher hand in the than the TDR standard 7-field imaging, and it also helped in changing the management decision in a significant proportion of cases. Coming to the usefulness of ultraviolet field, it can capture up to 3.9 times more area of retinal non-perfusion and 3.2 times more retinal surface area and 3.8 times more laser pan-retinal photocoagulation treated area, and it can it captured about 10% more pathology and also modified diagnosis and management in about 45.7% of our cases. It's an indicator for the predicting diabetic retinopathy severity worsening. Thus, it predicts the progression of non-proliferative diabetic retinopathy, and it also assesses the general disease commonality by assessing perfusion status and helps in detecting the diabetic macular edema and ischemic area higher hand. Then it also reduces the area and intensity of the treatment with laser because it can capture the peripheral ischemia as well, and the montage artifacts of the ultraviolet field is less, and it also recruits more proliferative diabetic retinopathy cases. Thus, ultraviolet field helps in identifying more treatment-worthy diseases which are often missed by the conventional angiography and increases the clinical outcome in patients. These are my references. Thank you.
Thank you. It's good presentation.
Yeah. Next, we have Dr. Shahana N.A. With indications and outcome of transepithelial photorefractive keratectomy extra.
Good morning all. Our study is on indications and outcome of transepithelial photorefractive keratectomy extra. Transepithelial photorefractive keratectomy, it is an advanced surface ablation procedure where excimer laser smooth and regularizes the corneal focusing shape. TransPRK extra is enhanced with an additional corneal strengthening procedure called corneal collagen cross-linking. Rarely, thinner corneas may progress into a condition called corneal ectasia. So, TransPRK extra is postulated to reduce this risk by strengthening the cornea in high-risk cases. There is no definitive inclusion criteria for selecting the patients for TransPRK extra. So, our study is to evaluate this indication, safety, efficacy and refractive outcomes of TransPRK extra. This is a retrospective study done in 29 eyes of 16 patients in a 1-year period, and we included TransPRK extra for patient with a central corneal thickness of 450 to 475 micrometer and keratometry above 46 diopters with a suspicious topography. The data collected included patients' age, sex, ocular medical history, details of surgery and complications, and the refractive outcomes were recorded during post-op visits at 1 week, 1 month and 6 months. This is the procedure. Preoperatively, 1 drop of proparacaine was instilled. Using excimer laser, TransPRK was done. Following TransPRK, an accelerated corneal collagen cross-linking treatment was performed. The riboflavin solution used was 0.1% and the soaking time before the UV radiation was 90 seconds and the energy used is 2.7 joules per centimeter square, which is half the strength in conventional corneal collagen cross-linking. 44% of the total sample included between the age group of 25 to 30 years and 83% of eyes had compound myopic astigmatism. Coming to pre-op parameters, the pachymetry, 48% had central corneal thickness of 450 to 475 micrometer and 52% sample has steep K above 46 diopters with suspicious topography. Intraoperatively, average stromal thickness was measured and about 55% had stromal thickness in range of 351 to 400 micrometer. And a refractive outcome, 96% had post-op uncorrected visual acuity, same as of preoperative best corrected visual acuity.
and about 21% had stromal haze in 6-month follow-up but not affecting the vision. Coming to discussion, our study included 29 eyes and we found that the stabilizing effect of refraction and it is a safe procedure. These are the two last studies done by Brar et al. And Farhad Hafizi et al. In Brar et al., 294 eyes were studied and they also found combined refractive surgery and simultaneous collagen cross-linking is generally safe and effective, and it also stabilized refractive and keratometric outcomes in patient. Farhad Hafizi et al. Study also shows it is safe, efficacious and very good refractive results and stabilizing effect of refraction, and no eyes had significant corneal haze at 12-month post-op. Nelopoulos et al. Also found a safe and effective adjunctive treatment for refractive regression and potential ectasia. Hanley et al. Study showed a transepithelial PRK combined with prophylactic corneal collagen cross-linking, and it is also found significantly reduced the magnitude of displacement of peripheral and central posterior corneal surface. So the study provided evidence for effectiveness of trans-PRK extra in stabilizing cornea despite a significant decrease in corneal thickness. It may not always feasible to perform flap-based refractive procedures in thin corneas with suspicious topography. So trans-PRK extra may be a safe and effective solution which gives an added advantage in high-risk cases. These are my references. Thank you.
You had op scan or pentacam?
Pentacam.
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 Pentacam, okay. Any epithelial topography alone you have done or not? Because you told epithelial you have to remove the epithelium and then do the PRK,
yes,
no?
Yes, sir.
Did you find out any epithelial topography, those patients? Epithelium
No,
alone, whether it is thinned out or something like that? No.
No, sir.
No.
This is done on suspected keratoconus or all thin cornea?
Thin corneas, sir.
Thin corneas,
No,
not suspected.
not suspect keratoconus.
Sorry, what was the follow-up period for this study?
6 months.
6 months. Totally 6 months.
Only 6 months.
But you found 21% having corneal opacity without affecting the
vision.
So the other study shown 12 months, no
12 months.
no corneal opacity.
Yes, sir.
So these type of things, do you think that 6 months is enough to have a conclusion?
No, sir.
Okay, thank you.
Next, we have Dr. Pavadi B. Raj. Her paper is on pachymetry changes following corneal collagen cross-linking for progressive keratoconus.
Good morning all. Our study is about the pachymetry changes following collagen cross-linking in progressive keratoconus. Collagen cross-linking aims to improve the intrinsic biomechanical characteristics of corneal stroma in order to stabilize progressive keratoconus. Then accepted criteria for undergoing a conventional collagen cross-linking include topographic evidence of keratoconus progression, corneal thickness more than 400 micrometer, and keratoconus without deep stromal scarring or history of corneal hydrops. The steps include, after instilling topical anesthetic drops, the central 7 to 9 mm of the corneal epithelium is debrided using a spatula, sparing the limbus. Then 0.1% riboflavin drops are instilled for about 60 seconds, and the riboflavin soaked corneal epithelium is irradiated with a UVA radiance of 370 nanometer with a total dose of 5.4 joules per centimeter square is applied. So here the riboflavin acts as a photosensitizer which limits the depth of effect, and the UVA radiation will helps the riboflavin to form free radicals and a singlet oxygen, which will helps in the formation of stronger covalent cross-linkings. So even though there are many protocols, we currently follow the one which is found to be effective and comparable to the conventional Dresden protocol, that it delivers about 9 millivolt per centimeter square for 10 minutes, and the conventional Dresden protocol delivers about 3 millivolt per centimeter square for 30 minutes. The criteria used to document progression according to the global consensus on keratoconus and ectatic disorders include a steepening of anterior corneal surface and steep K of more than 1 diopter increase from the baseline for about 1 year, in a 1 year period, and a flattest keratometry of more than 1 diopter increase from the baseline, and a mean keratometry of more than 0.75, and a manifest spherical equivalent of more than 0.5 diopter increase from the baseline, and also includes the thinning or changes in the pachymetry of more than 2% from the baseline, and at least 2 of the following should be there. We tries to establish that even though the pachymetry decreases following cross-linking, the keratometric parameters remain stable. Hence, pachymetry changes cannot be considered as a criteria for progression after cross-linking. We had done a retrospective study for about 1 year, and 59 eyes of the patients with progressive keratoconus who underwent C3R are taken into account, and pre and post-operative, that is after 1 year, pachymetry values and simulated K values in the steepest meridian are taken into account. And we found that the mean maximum steep K parameters were decreasing from the 55.6 to 53.9 with a pair difference of about 1.68 diopter with a p-value of 0.01, which is found to be statistically significant. That is, the keratometry is the progression of keratoconus is halted. And the pachymetry is found to be decreased from 438 to 411 with a pair difference of 26.6 micrometer with a p-value of 0.001, and which is also statistically significant. So the decrease in the mean pachymetry and the slight widening of the range suggests that the treatment resulted in a significant thinning of the cornea in keratoconus patients, and this finding aligns with study's primary objective, which states that pachymetry decreases following cross-linking while keratometric parameters remain relatively stable. Similar studies done by Wolenczak et al., Hendricks et al., and Albright et al. Also showed that the pachymetry values were decreasing following cross-linking in a 1 year period, and the keratometric parameters were remaining stable. So, to conclude, the collagen cross-linking is effective in stabilizing corneal shape in keratoconus patients despite a significant decrease in corneal thickness, which suggests the need for changes in the criteria to assess the progression after cross-linking. These are my references. Thank you.
You have used what? Pentagram or again the op scan? Pentagram. Then cross-linking, you had any opacities? No. Developed? Because in pentagram, the thickness of cornea may vary from the opacity. From the opacity, you can have the measurements sometimes.
In a 1 year period, opacities were not noted.
Not seen.
So your conclusion is need not to worry about corneal thickness, no? That is the actual process of cross-linking because it increases the strength of the cornea. So you will be only followed up with the keratometric reading, topography. Okay. You will be following so that there is no need to assess the corneal thickness in follow-up. Yeah, if it is you are not considering as a significant thing, you can stop following up the thickness. No, thank you.
Next we have Dr. Srikuti Anand talking on visual acuity and complications after cataract surgery in diabetic and non-diabetic patients.
Good morning. This is a topic on a comparative study of visual outcome and complications following cataract surgery in diabetic and non-diabetic patients. The aim of the study is to compare the visual outcome and complications after small incision cataract surgery in diabetes and non-diabetic patients. Materials and methods, study design. It's a comparative study of 1 year duration with the study population of 2 groups. Group 1 with patients undergoing small incision cataract surgery with diabetes mellitus, and 2 without diabetes mellitus. Inclusion criteria: the patients undergoing small incision cataract surgery between the age of 40 and 80 years, and we excluded traumatic cataract, complicated cataract, posterior segment cause for visual losses, secondary glaucoma, neovascularization of the iris, and the sample size were 174 eyes calculated from a previous study by Soumya, and it included 87 eyes in diabetic and non-diabetic group, and the sampling method used was convenient sampling. Methodology and data collection: preoperative visual acuity, anterior and posterior segment findings were noticed, and after cataract surgery they were followed up with visual acuity, slit lamp and fundus examination on postoperative day 1, 7 and day 30. And the data was tabulated after converting Snellen's vision to logMAR values and was analyzed by SPSS software. And if the p-value is less than 0.05, then the result is considered to be statistically significant. And the results, 174 eyes were studied, of which 87 eyes in each group, and the mean age of the study population was 66 plus or minus 7 years, with slightly lower in diabetic group. And best corrected visual acuity in logMAR in the preoperative period showed no statistically significant difference with a p-value of more than 0.05, and after the surgery on postoperative day 1, 7 and after 1 month after the cataract surgery, it showed a statistically significant difference in these groups, with poorer visual outcome in the diabetic group. And the most common type of cataract seen in both the groups were nuclear sclerosis, followed by posterior subcapsular cataract. And the early complications noticed in postoperative day 1 were corneal edema and anterior chamber fibrinous reaction, which were more common in the diabetic group with a p-value of less than 0.05. And after 1 week, majority of these complications were resolved, and only corneal edema persisted in 6 patients in the diabetic group, while it completely resolved in non-diabetic group with a p-value of 0.003. And late complications, that's after 1 month, posterior capsular opacification and the macular edema were seen more significantly in diabetic group with a p-value of less than 0.05. And the mean age of cataract were lower in diabetic group in this study, similar to a study by Fleischer et al. And Framingham eye study. And the type of cataract seen in this study is nuclear sclerosis, which is the most common one. And in Blue Mountain eye study, it showed cortical cataract, and Kesseltropak and Tekin et al. Showed posterior subcapsular cataract as the most common one. And the final visual outcome was poorer in the diabetic group in this study, and a multicentric database study by Chancellor et al. And Kelkar and Mehta et al. And in the study by Soumya showed no significant difference in outcome in both these groups. And the early complications like anterior chamber fibrinous reaction were more common in this study, similar to a study by Ivancic et al. And the corneal edema were more common in diabetic group in this study, similar to a study by Soumya. And the late complications like PCO formation were more common in this study and study by Ivancic, Ebihar and Kato et al. And Hayashi. And the macular edema was common in this study, just like this study conducted by Ivancic et al. Conclusion: the mean age was lower in diabetic group. Nuclear sclerosis was the commonest type in both the groups. Visual outcome was significantly lower in diabetic group, and the early postoperative period showed higher incidence of anterior chamber fibrinous reaction and corneal edema in the diabetic group, whereas in late postoperative period showed macular edema and posterior capsular opacification more in diabetic group. Thank you.
Any reason for having this PCO more in diabetic groups?
More inflammatory reactions, inflammatory cascades, mediators are more common, more in diabetic group.
In diabetic also, in non-diabetic also they have developed some PCO.
If the migration of the lens epithelial cells is also the cause for PCO formation.
Okay, thank you.
Next, we have Dr. Anjana Verghese. She will be talking on OCT patterns of diabetic macular edema in patients with diabetic retinopathy.
Good morning, everybody. My paper is on OCT patterns of diabetic macular edema in patients with diabetic retinopathy. The aim of my study is to characterize the different morphological presentations of diabetic macular edema using optical coherence tomography and to ascertain the prevalence of each pattern and to correlate the glycemic control status, DM duration and mean age of presentation with respect to each DME pattern. It was a hospital-based prospective observational study conducted in the Department of Ophthalmology, MAS Medical College, and the study population was the DME patients receiving injection bevacizumab. My sample size According to my parent study by Sharma et al., the sample size calculated for my study was 88 eyes. The study period was from 1st September 2022 to 31st of August 2023. And the inclusion criteria was patients with DME needing injection bevacizumab, and exclusion criteria was patients with media opacities that affect OCT imaging, previous history of photocoagulation in past 3 months, previous history of intraocular surgeries in the past 3 months. The methodology I adopted was each participant is categorized into one of the 3 types of diabetic macular edema based on the characteristics observed in OCT: diffuse retinal thickening, cystoid macular edema, and serous retinal detachment. When SRD coexisted with other patterns, it was taken as SRD. And data was entered in Microsoft Excel, and analysis was done using SPSS 25 license version. And coming to the results, the mean age of presentation was 58 years, and it ranges between 50 to 65. Out of 88 patients, 61 were males and 27 were females in the study population. The mean duration of diabetes was 15.69 years, that is around 16 years. 23.9% of them, that is 21 of them, had good glycemic control, while 76.1%, that is 67 of them, did not have good glycemic control. Now coming to the OCT pattern, among 88 eyes, the most common OCT pattern observed was cystoid macular edema, that is 58%. So out of 88 eyes, 51 showed CME. Then diffuse retinal thickening in 25%, and the least common being serous retinal detachment in 17%. Now coming to the mean age, it was comparable, and it was around 57 to 59 in all 3 groups. Comparing the duration of DM and OCT pattern, it was also comparable. It was around 16 years in all 3 groups. Comparison of sex distribution and OCT pattern. Here all the 3 groups showed male predominance. And comparison between the glycemic control and OCT pattern, all the 3 groups obviously had major population with poor glycemic control, and we can see that I got a result that in SRT group we had the major poor glycemic control status. Coming to discussion, in our study, most common OCT pattern observed was CME, same as in the study by Otani et al. But in a study by Kim et al., they got the most common OCT pattern as DRT. And coming to the sex distribution, in our study there was male predominance, as well as in the study by Yüksel et al. But in a study by Sohailian et al., they got female preponderance. Coming to the age distribution, in our study, the most commonly people belong to the age group of 58-59, and same, almost comparable to the study in Gu et al. But in the study by Huiskam et al., the most common age group was around 78. So the study showed predominance of males in all the 3 groups. The comparison of mean age, sex distribution, and duration of DM between all 3 groups did not show statistical significance, that is the p-value was more than 0.05, and poor glycemic control was more prevalent in SRD groups when compared to the other 2. Coming to the conclusion, cystoid macular edema was the most common OCT pattern, followed by diffuse retinal thickening and serous retinal detachment. SRD group had a higher percentage of patients with poor glycemic control compared to the CME and DRT groups. Male predominance and mean age being 58 years with a mean duration of 16 years was found. These were my references for the study. Thank you.
How come you have selected 88 as a sample size? Which any formula you applied? Because you selected 88 eyes.
That was according to my parents' study, sir.
Why you have not shown any OCT pictures?
I'm sorry, sir. I should have included pictures. I'm sorry.
Because everything, suppose you put a OCT picture side by
So,
side.
my DRT pattern means diffuse retinal thickening, the kind of spongiform thickening of the retina. In cystoid macular edema, we can see intraretinal cystoid spaces.
You should have shown some pictures. It would be useful.
Okay. Sorry, sir.
Okay.
Okay, sir. Sorry.
Because
I'm
it's a
sorry.
competition. It's a competition. You have to show all these things. Then only it can attract.
I'm sorry, sir.
Okay.
Thank you. Next, we have Dr. Anjita B.S. She'll be talking on primary versus secondary IOL implantation in congenital cataracts, a comparative study.
A very good morning to one and all. So my topic for the study is primary versus secondary IOL implantation in congenital cataract, a comparative study. So congenital cataracts are the third leading cause of visual impairment in children following congenital glaucoma and inherited retinal disorders. Numerous prenatal, metabolic, toxic, viral or genetic disorders are typical factors linked to its gradual development. And to avoid irreversible amblyopia, surgery for a congenital visually significant cataract must be done as promptly as possible. And the controversy remains on the method of correction of the resulting aphakia that depends on the age of the child at the time of surgery. And intraocular lens implantation is typically required to restore vision, though primary IOL implantation is not generally recommended for children aged less than 2 years of age. And the aim of the study was to compare visual outcome, principally the myopic shift, visual acuity and biometric profile between children who have undergone primary and secondary intraocular lens implantation following congenital cataract surgery. And our study design was a retrospective intervention study that include children with congenital cataracts who underwent either primary or secondary IOL implantation at a tertiary care center during the period from 2010 to 2020. Study duration was 20 months from December 2022 to July 2024, and a sample size was 112 patients, 56 in each group. And pre-operative and post-operative assessment of each operated eye in terms of axial length, refractive errors, ocular alignment, and post-operative biometric profile and best corrected visual acuities were collected. And the subjects were classified into 3 groups, that is from 1 to 5 years, 6 to 10 years, and 11 to 15 years for age-associated biometric changes. And the biometric profile parameters were measured using the IOL Master 700, and the data were retrieved and reviewed. The primary IOL patients averaged the mean age at surgery for primary IOL patients averaged for 84 months compared to 5.9 months for primary surgery in secondary IOL patients. And the inclusion criteria was congenital cataract, both bilateral and unilateral, normal corneal diameter, normal intraocular tension, and patients with at least 1 year postoperative follow-up. The exclusion criteria was we excluded patients with microcornea, microphthalmia, megalocornea, then anterior or posterior synecdoche, elevated intraocular pressure, and patients with any other ocular pathologies, poor fixation, and cataracts other than congenital cataract. And the procedure was performed under general anesthesia, and it includes creation of a corneal incision followed by anterior capsular rhexis and lens aspiration. Then posterior capsular rhexis and anterior vitrectomy is done for all patients younger than 6 years old, and implantation of intraocular lens or leaving aphakic for later correction depending upon the age. And the data was entered in Excel and analyzed using the SPSS software version 20. And coming to our results, in our study comparing 112 participants, unilateral surgeries were more common in both groups, and a best corrected visual acuity of 6/6 to 6/9 was reached by 71.4% of the primary group versus 17.9% of the secondary group. And the proportion of patients with best corrected visual acuity worse than 6/24 was significantly higher in the secondary IOL group compared to the primary IOL group. And on comparing, on comparing the postoperative outcomes, between the primary and secondary intraocular lens group, significant differences were noted in ocular alignment also, and the primary IOL group had no cases of esotropia, while 14.3% of the secondary group did, and exotropia was observed in 5.3% of the primary group versus 21.4% in the secondary group, and nystagmus was seen only in the secondary IOL group. And this comparing these results in biometric profile, this highlights the significant biometric changes, especially in axial length and AC depth following cataract surgery compared with normal children of the same age group. And good visual acuity was achieved by 67.8% of the primary IOL group compared to just 17.9% in the secondary IOL group, and that highlights the critical period for visual development in pediatric patients. And this findings aligns with the critical periods of visual development proposed by Mohammed et al., emphasizing the necessity of early and effective visual correction to prevent amblyopia. And the ocular alignment outcomes showed a significant incidence of strabismus in the secondary IOL group, consistent with the findings by Trivedi et al. And the nystagmus was absent in the primary IOL group but present in secondary group, emphasizing the importance of early visual rehabilitation in preventing sensory deprivation nystagmus as suggested by Lambert et al. And both groups demonstrated similar axial length measurements and changes with significant myopic shift in the secondary IOL group. And a notable post-operative biometric changes, particularly in axial length and AC depth in both primary and secondary groups, aligns with the results reported by Abrar et al. And our conclusion is children operated with primary IOL showed significant improvement compared to secondary IOL, and the incidence of strabismus was significantly lower in the primary IOL group, and the changes in axial length and AC depth were similar in both groups, and the findings emphasize the critical role of early IOL implantation in preventing visual deprivation, amblyopia, and strabismus. So these were the strengths and limitations of our study. Thank you.
Primary IOL means what?
Sir?
Primary IOL told at what time the surgery was done?
Sir, primary IOL was done for children aged more than 2 years of age.
Then what about suppose the congenital cataract is significant? When do you normally advise surgery when?
Means if a cataract is significant, if it is a unilateral cataract, significant unilateral cataract, then surgery is done immediately.
Bilateral?
But bilateral significant cataract also
that time you are not applying IOL. That time you are not supposed to apply IOL, no? Suppose you are doing within 4 and 8 weeks, how can you apply IOL?
For less than 2 years of age, we don't recommend a primary IOL implantation.
You have to do surgery, no?
Sir.
Then you are telling primary IOL after 2 years. The first surgery you have done without IOL only.
First surgery we maintain the patient aphakic and we use other optical correction like contact lens.
No, you told primary, secondary IOL.
Yes, sir.
So first surgery you have done without IOL.
Yes, sir.
You are told primary IOL done after secondary 2 years means why? I do not know. I can't understand.
Sir, primary IOL is done for if the patient is aged more than 2 years.
That is okay, man. That means first surgery was not done before 2 years.
If the surgery is done before 2 years means then we maintain the child aphakic, sir.
Aphakic, but the surgery you are telling, secondary IOL.
Secondary IOL surgery is done after like 20 months.
That is okay. First time you are doing surgery, you have not done IOL.
Sir.
Second time you are going to implant IOL. That is called secondary IOL.
Yes, sir.
But first time you have not made aphakic, then second time you are applying IOL. Now you are telling primary IOL, secondary IOL. Something is confusing.
Primary means only one procedure.
For primary IOL implantation, there is a single procedure that we do for patients aged more than 2 years.
That means nystagmus naturally you can expect because macula develops by 16th week. Naturally you can expect nystagmus to come and squint to come. Why did you wait for 2 years for this first surgery?
Pardon, sir, I didn't understand.
See, if you wait for 2 years and all, naturally the child is liable to develop nystagmus and squint. You are telling primary IOL done at 2 years means that means you have not done surgery before that. You have to make IOL, child aphakic only, so that the light can go inside and exact the macula to develop. Otherwise, macula will not develop.
Sir, but the outcomes, like we are comparing the outcomes of...
The word you are using is, I feel wrong. Because you told primary IOL up to 2 years, there is something wrong. Understand now? You are able to follow me. Normally, you are supposed to do congenital cataract surgery if it is significant within 8 weeks.
Yes, sir.
That's the ideal time. That time you are not going to apply IOL. Now you have to apply IOL means now you have to wait for 2 years or something you are waiting.
Yes, sir.
That is called secondary IOL only. Secondary surgery only you are doing. It's not primary IOL.
No, sir. We are comparing the outcomes of both patients, like how what is the myopic shift, visual acuity, etc. for both primary and secondary.
I'm not concerned with that. The word you are using is primary, secondary. I am having my own doubt. That's all.
Okay. Thank you. Thank you.
Next, we have Dr. Alfia Rashid. She is presenting on retinal microvascular changes in coronary heart disease patients and OCT angiography based study.
Good morning all. My topic for today is retinal microvascular changes in patients with coronary artery disease and optical coherence tomography angiography based study. So the rationale behind my study is like recurrence risk of an acute event in a CAD patient is 1 in 5 patients. So these are accurately diagnosed with coronary CT angiography and coronary angiography. But we can't always prefer this in a mild symptomatic patient, follow-up patient. So thus we aim to conduct a study about retinal vascular changes through non-invasive OCTA in CAD patients which are treated in different modalities. So the objective of my study is to use a non-invasive opta to study the microvasculature, vessel density and blood flow on the retina in those with CAD and those who do not have CAD, and to determine whether alternation in the ocular vasculature and microcirculation can indicate a coronary heart disease lesion. So the study was conducted in a coronary care center in the Department of Ophthalmology and Cardiology. It was a case control study for a period of 1 year in eyes with the patients who is having CAD and no history of CAD, and sample size were 100 patients. So we included patient who is a non-case of CAD, who is on follow-up, who underwent coronary angiography within last 6 months as the cases, and who is having no history of CAD as the control. Diabetes and hypertension were included. If included, it will be medically controlled patients. And we excluded patient who is having prior history of intraocular surgery, retinal diseases, glaucoma, diabetic retinopathy, and hypertension retinopathy, and media obesity that may hinder the OCTA imaging. So the CAD patient and non-CAD patient underwent a complete ophthalmological evaluation and OCT angiography. In CAD patient, in addition, syntax scoring was done, ejection fraction and serum creatinine was measured. So the syntax score is actually the degree of coronary artery disease and its complexity, and it is categorized as low, intermediate and high. High means the patient is having a complex CAD or more severe CAD. The treatment modalities of CAD patients included medical management, percutaneous transluminal coronary angioplasty and coronary angiography bypass graft. The OCT angiographic parameters which we studied is in the superficial capillary plexus, which included the vessel density, perfusion density and the foveal avascular zone through the ETDRS grids shown below. It is having an inner 3 mm and outer 6 mm circle. And the results came out to be most of the age group were between 50 to 70 years of age group, and the distribution of CAD was like 40% underwent PTCA followed by CABG and medical management. So the relation between syntax score with the OCTA parameters was considered, and we found that the low syntax score, that means less severe CAD, is having better outer vessel density and full vessel density, similarly better perfusion density. But the patient who is having high syntax score, that is more severe CAD, is having a decline in the vessel density and the perfusion density. Similarly, the FAS area is well maintained if the patient is having low syntax score or the less severe CAD, and the high syntax score or the more severe CAD is having worsening of the FAZ zone. And we compared the ejection fraction with the OCTA parameters. Most of our patients were having ejection fractions more than 55%, which is normal, and it doesn't had any significant correlating with the OCTA parameters because we had taken treated CAD patients. And serum creatinine also was taken, which was in the normal limit, less than 1.4 milligram per deciliter in most of the patient. Hence we didn't find a correlation with the OCTA parameters and the serum creatinine levels. The comparison between the OCTA parameters with each CAD subgroup and control were studied. It is seen that the medicine group is having decreased value comparing the control group, and PTC and CABG is having similar values, and it is similar to controls also, and these values were statistically significant. So discussion, the CAG and PTCA showed a better retinal OCTA parameters comparing to medically managed people and were similar to control groups. It is recommended by ACC and ESC that PCA based invasive strategies may improve the long-term survival and circularity compared to a medical only management. And cardiac severity, which is assessed by the syntax score, showed that the less severe CAD has better vessel density, better perfusion density and FAZ. Wong et al. Actually proposed that the retinal microvasculature is considered as an easily measured surrogate for the coronary circulation. So less severe CAD has a better perfusion maintenance. Compared with the other studies, Song et al. Study in suspected angina showed reduced vessel density in SCP and DCP, and Wong et al. Study in the coronary heart disease showed a reduced flow area and vessel density. IMA study in acute coronary syndrome showed a stronger relationship between the HA risk and the vessel density. So we concluded that the medical management was inferior to PTCA and CABG in treating a CAD patient, and the severity risk score by syntax scoring was linked to the superficial capillary plexus in the OCT angiography. And there is an independent yet statistical association between the each management subgroup of the CAD and the retinal microvascular changes in the OCT angiography. So the limitation of my study was superficial capillary plexus was only studied in my study because our machine was HD OCT 6000 and there is limited sample size. We had not taken any acute event patients and controls were pseudo controls because not taken angiographic proven controls. So recommendation to forecast a current status of the CAD with the normogram including the retinal OCT angiography, clinical features and echocardiography, and if a patient develop new symptoms or worsening of the CAD, we can follow up with the OCT angiography and if needed we can do the invasive procedures later. And further a prospective study should be considered in large sample size in future for more detailed evaluation and prediction of acute events in CADs. These are my references. Thank you.
You suggest Octa in every cardiac patient?
Not every cardiac patient. If he's having any symptoms or mild symptoms or he's having doubtful symptoms, we can consider Octa before doing for the
also
expensive.
this will be used in follow-up.
Yeah, it is better. In my study, it is proved that it is better. Thank you.
Now we have the last presentation for the session. Dr. Mahida Narayanan on Does cataract surgery increase risk of sequential NAION?
Good morning all. My paper is on Does cataract surgery increase the risk of sequential NAION? So, non-arteritic anterior ischemic optic neuropathy is the most common cause of acute optic neuropathy above 50 years and the exact pathophysiology is unknown but thought to be due to hypoperfusion of short posterior ciliary arteries causing acute ischemia to optic nerve head. So this acute ischemia to optic nerve head lead to axonal swelling, compromise the axoplasmic flow and compression of optic nerve head microcirculation leading to ischemia and as a vicious circle causing compartment syndrome, later leading to infarction and death of retinal ganglion cells. Optic nerve head perfusion is mean arterial BP minus intraocular pressure. Anything that increase the IOP or decrease mean arterial BP can lead to ONH perfusion pressure imbalance. So we have to avoid nocturnal hypotension in patients who are taking antihypertensive at night have to be avoided. So the risk factors, mostly vasculopathic risk factors like hypertension, diabetes, hypercholesterolemia, smoking and obstructive sleep apnea is considered. Other risk factors, medication like phosphodiesterase inhibitors, a disc at risk like small ONH with small CDR and optic disc occlusion. Our aim of the study is to analyze if cataract surgery increase the risk of sequential NAION. So we collected the data retrospectively, retrospective cross-sectional study with 88 patients with documented NAION aged above 40 years who came to our tertiary care center between January 2013 to January 2023. We included the patients who had undergone cataract surgery and those who didn't. Systemic risk factors were considered. Out of the 88 patients, 37 had undergone cataract surgery, 51 without cataract surgery included. We collected data retrospectively from the EMR of patients with NAION and presence of risk factors included. We taken the clinical history, fundus photograph, HFA except in poor vision patients, OCT and MRI brain to rule out other causes included. Cases with findings not confirmatory for NAION were excluded. And the parameters assessed were demographic data, visual acuity pre and post cataract surgery, RAPD and color vision, eye and the type of surgery, systemic risk factors, and if any other ocular surgery done during the study period. Follow-up was 6 months. So the results, male outnumbered females in our study. The mean age was 65 years and 37, that is 42% undergone cataract surgery. Systemic risk factors in 75.7 patients were known and diabetic was the most common systemic risk factors. So 42% of our population had undergone the surgery and 60 didn't. NAION in same and contralateral eye was 81.1 in contralateral and 18.9 in same eye. So best corrected visual acuity prior to surgery was 6/24 or worse in majority, and best corrected visual acuity 6 months follow-up period was 6/9 or better. The type of surgery done, phacoemulsification in 95% and 5% had SICS. No intraoperative complications were noted and no one had any other ocular surgery during the study period. Out of the 88 patients with NAION, no one developed NAION in the contralateral eye during the study period, and in the group undergone cataract surgery also, nobody developed NAION in the same or contralateral eye during the follow-up period. These were the studies we considered. In Lambie et al., the retrospective cohort study, 325 patients with 17 undergone cataract surgery, 9 among them developed NAION, and without cataract surgery, 308 patients, 59 developed NAION in contralateral eye. In Makkal TJ, the incidence was 51.8 out of 1 lakh in 6-month follow-up period and 34.6 per 1 lakh in 6-week follow-up period. So our observations with modern cataract surgery techniques and instrumentation lacks fluctuation in the anterior chamber and intraocular pressure and good postoperative follow-up. Post-cataract surgery, optic neuropathy due to NAION has been minimized and systemic risk factors were well controlled. The limitation of my study, retrospective nature, low sample size, short follow-up period, and some variables not known were exact time of NAION development, exact cup disc ratio, metabolic profile, and smoking history. Long-term follow-up is needed to assess the stability of results. So, concluding, cataract surgery did not increase the risk of sequential NAION in our study. These were the references. Thank you.
Do you take BP for all the patients? Blood pressure?
Yes, on the coming to the
did you measure the CRA pressure, the blood pressure?
Sir, it was a retrospective study, so it was in the EMR, most of the patients.
Any blood pressure of CRA was calculated. Do you know how to calculate?
Not in all patients.
No, do you know how to calculate CRA BP?
CRBP in...
Central because you told perfusion pressure based on the arterial BP.
No, we didn't. In ICU and all.
Do you know how to be record?
No, sir.
No. We
I have seen, but
ophthalmic dynamometer was there those days.
Okay.
We were measuring the intraocular, that is a BP of CRA with ophthalmic dynamometer. And if you are not having that, you are taking BP, normal BP.
Yeah.
You take 2/3 as systolic,
yes,
and half of the systemic is diastolic, approximate. Then you know IOP. You can calculate the perfusion pressure.
Yes.
Okay. Thank you.
Thanks.
Thank you for all.